Welcome to our webinar titled MDS Update from the 2022 EHA and ASCO Research Meetings. Thank you for joining us. My name is Lee Clark, Director of Patient Services, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the program. Today's program will be archived to the website within 2 to 3 business days. You'll be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Our specialist today is Naval Daver. Dr. Daver is an associate professor in the Department of Leukemia at MD Anderson Cancer Center and the director of the Leukemia Research Alliance program. He is a clinical investigator with a focus on molecular and immune therapies in AML and myelofibrosis, and is a principal investigator on many ongoing institutional, national, and international clinical trials in these diseases. These trials focus on developing a personalized therapy approach by targeting specific mutations or immune pathways expressed by patients with AML, evaluating novel combinations of targeted immune and cytotoxic agents, and identifying and overcoming mechanisms of resistance. He is especially interested in developing monoclonal and biospecific antibodies, immune checkpoint and vaccine-based approaches in AML, MDS, and myelofibrosis, and is leading a number of these trials at the MD Anderson Cancer Center. It's my pleasure to welcome Dr. Daver. Thank you so much for joining us.
Okay, thank you very much for having me. It's a pleasure to speak to you all today about the progress that's happening recently in the treatment of MDS. And I'll be focusing on updates from the last year ASCO meeting, EHA meeting, and there's of course upcoming data that I'll kind of allude to briefly at the ASH 2022 meeting, which is going to be in December 8 to 12, so coming up soon in New Orleans 2022. So to start with, it's really important to realize that MDS is a very heterogeneous condition, and not only are there different molecular mutations as well as chromosome abnormalities, there's also differences in the blast proportions. And so we have, over the last 2 decades, been refining our classification of MDS to lower risk populations and higher risk groups. And the reason we really do this is primarily to decide which patients need treatment early on versus whether there are some patients where treatment does not need to be started right away. They are so low risk that they may not have progression for years, and in some cases never, where we could adopt a watch and wait approach. So this is why this classification that your physicians may talk to you about are being used. Now, even before the low-risk MDS, we have started identifying a group of entities called CHIP, which is clonal hematopoiesis of indeterminate prognosis, or CCUS, which is clonal cytopenias of unknown significance. So these are patients who have some degree of drop in blood counts, do not have clear morphological evidence of MDS on the bone marrow. The pathologist cannot call it MDS, but they do have some clonal changes in the sequencing. And so we are considering this as a pre-MDS, or a very early change that could lead to MDS. The problem is at this time, we don't know exactly what proportion of patients and what clonal changes can predict. So this is something you may come across. It's still in very early research. At this point, we're not treating people routinely with CHIP or CCUS, but we are doing increased monitoring, and a lot of data is being collected to help us understand this entity better and treatments better. So this is kind of the general landscape of the phases of MDS, CHIP, CCUS, low-risk MDS, and then high-risk MDS. So when we look at the treatment algorithm for MDS, we really do divide these patients, whether you're using the IPSS or the more recent called the revised IPSS classification, into higher risk and lower risk. Based on the risk, we treat these patients either with hypomethylating agents or with clinical trial approaches, or in some cases, in younger patients especially, we may even use intensive chemo, trying to get the patients quickly into a deep remission to proceed with allogeneic stem cell transplant with a curative approach. There's also, of course, molecular data that we look at, which can help further refine the treatments with the addition of targeted therapies. I'll talk about those a little bit later. And then for patients who are considered truly lower risk, and the IPSS and RIPSS were based mainly on the bone marrow blast, the cytogenetics, the degree of anemia, and the degree of low platelets, thrombocytopenia, and transfusion requirements. So they did not incorporate molecular information, because this is something we've been doing much more recently. But with the incorporation of molecular information, there is now a new classification called molecular IPSS. This was just published a couple of months ago, and I think that is probably going to be the one we end up using the most in the coming years, because we do see there are some patients with lower risk MDS by the cytogenetics and bone marrow blast and cytopenias, but if they have high risk mutations like TP53 or others, they are still considered to be patients who do need treatment earlier than later. So just something to know about, that molecular mutations are not in the traditional classification, but do have additional prognostic impact that could give additional information or even supersede the traditional things such as bone marrow blast, cytogenetics, etc. And then for lower risk patients, the focus usually for those who are truly lower risk, many of them may not progress for years. The goal is to keep them free of transfusions, have them out of the hospital, try to improve blood counts and reduce the infection rates. We're not as worried about transformation to AML or progression of the disease, but more on the supportive care measures, which can be very important. So in the lower risk population, there are 2 or 3 key things that I think we need to highlight. So there is a group of patients who have what we call a chromosome 5 abnormality. These are called 5q MDS. So this is something most MDS patients will have or should have checked, checking for chromosome 5q abnormality. And the reason is, if you have a chromosome 5q abnormality, those patients respond very well to a drug called lenalidomide or Revlimid. And this was a large study that was done predominantly in Spain a few years ago, where patients were randomized, patients who had deletion 5q MDS with or without other abnormalities. As long as they had the deletion 5q, they were eligible, and they got either the lenalidomide or just a placebo. These were all lower risk patients using the IPSS, which was the classification that was being used earlier on when this study was done a few years ago. And what they actually show was that this approach was very, very effective. So patients who received lenalidomide, we see that there was a significant decreased transfusion dependency. 61% of the patients became transfusion independent. So that's a significant reduction of transfusion dependency. And we also see that the time to transfusion dependency, meaning the time for them to lose their transfusion independence response, was actually much longer, more than double, 6 years versus 2.8 years for the placebo. So basically showed that lenalidomide was very, very effective, reduced the risk of transfusions quite significantly, and also the duration of remaining transfusion independent, which is really the key endpoint we're looking for in patients with lower risk MDS, was very long, 6 to 7 years. And so this was a good supportive study. There have already been studies many years ago showing that lenalidomide was effective, but the key point here is to check for the deletion 5q or chromosome 5 abnormalities in your bone marrow. This can be done with simple chromosome analysis, and if it is there, then strongly consider and discuss the potential of using lenalidomide to improve blood counts and remain transfusion independent, could be for many, many years. So then the other significant development that's happened in the last 2 years or so is the availability of an oral formulation of hypomethylating agents. So for many of you who are patients or caregivers or treating MDS, you know that historically the treatments that we have used for MDS have been IV therapies, either azacitidine or decitabine. But recently, there has been an oral formulation of decitabine that was shown to be in the lab equivalent to the IV decitabine. This is called the ASTX727 oral decitabine formulation. And there was a study looking at the comparison of the oral decitabine to the IV decitabine to see if these gave us similar responses and outcomes. And so this was really based on PK, pharmacokinetics, just to make sure that the oral decitabine was able to achieve similar levels and give similar response rates to what has historically been achieved and published and used as a standard of care with the IV decitabine. You see that the inclusion criteria patients who would have otherwise gotten IV decitabine, who had a good performance status, very standard inclusion criteria for these patients, and 69 patients were enrolled, and this data was presented by Dr. Garcia-Manero from MD Anderson. So here you see that overall, the response rates were very similar to what we have historically published with IV decitabine. The CR rate was 23%, and the overall response rate, including CR, marrow CR, hematological improvement, was about 56%. In fact, this is a little bit better than we have seen with IV decitabine, where historically the CR rates were about 15 to 20%. Now, this could just be a little bit of a different patient population, different bone marrow time points in this study and other factors, but I think both the FDA as well as the treating physicians as well as the principal investigators of this study were all quite confident and comfortable that this was at least as good as what we have historically seen with IV decitabine. The CR durations were very similar, again, a little bit better than what has been seen with IV decitabine, and there were patients who were eligible, went to transplant. So the simple summary is that this has now been FDA approved as a potential replacement or alternative for IV decitabine. We do have a number of patients with MDS that we have seen in the last year and a half, where we have started the oral decitabine instead of starting with IV decitabine or IV azacitidine. We have avoided switching patients midway from IV decitabine to oral decitabine. There's very limited data for that, but I think if that is something of real interest, it could be considered with some close monitoring. But in general, we have been using this for frontline for newly diagnosed MDS patients who prefer the oral option. Now, of course, the cost is higher, and so this has to be run through insurance and make sure that this is covered. But I would say 90% of my patients, of course, do prefer the oral option if the insurance is able to cover it, which we are seeing most insurances are able to do. So the other important thing is transfusion independence. This was quite similar with the oral decitabine, IV decitabine, what we have seen historically. So no major issues on that front. And then overall survival also was quite similar to what has been seen historically with the IV decitabine, actually maybe a little bit better. So for all reasons, we think the oral decitabine is a good option to consider for higher risk MDS patients who would be candidates to start IV hypomethylating agent therapy such as IV decitabine or azacitidine. So what are the other agents that are in development in lower risk MDS? So one of them is very important, drug called luspatercept. This has been approved also recently. This is an agent that improves hemoglobin. So for patients who have anemia as their main presenting issue or requiring red cell transfusions, we use erythropoietin stimulating agents or growth factors. Historically, for the last 20, 30 years, we've used drugs like Procrit or erythropoietin or Aranesp, and these work in 50 to 60% of patients with MDS to improve hemoglobin to a point where transfusions are not needed. But a number of patients will eventually fail, or 30, 40% will not respond to this traditional erythropoietin growth factors. And so for those patients, there's a new drug called luspatercept, which is a other erythropoietin growth factor, but it works through a different pathway and has now been approved for patients who are failing the standard Aranesp, Procrit, erythropoietin stimulating agents. And I've treated a number of patients who have failed Aranesp or other such standard erythropoietin stimulating agents with luspatercept and have seen very good responses with it. So again, an important drug to consider in your patients with MDS with predominant anemia or red cell transfusion who are progressing after having received 3 to 4 months of a traditional erythropoietin stimulating drug such as Aranesp, Procrit. I would try luspatercept first if anemia is their main problem. And then some of the others are pretty early in development. We're waiting for clinical trial data, and we will hopefully have updates in the near future. So now moving to what is probably the most important and the most significant area of clinical research ongoing in MDS today is patients with what we call higher risk MDS. So when you see all MDS patients, whether you use IPSS or RIPSS, which is the revised IPSS, about 50% of patients, 50 to 55% of patients fall into the higher risk. The higher risk usually includes very high, and intermediate risks according to IPSS-R, or the very high and the high according to IPSS. Usually these also tend to be patients who have higher bone marrow blasts. There's quite a close correlation between bone marrow blast percentage and being higher risk. And also often they tend to be patients who have adverse cytogenetics or cytogenetic abnormalities, and sometimes high-risk molecular mutations. And as you can see, there's been a lot of efforts to move beyond or to build on the hypomethylating agent approach for these patients. And we're combining other drugs based on a lot of preclinical work to try to improve response rates and eventually survival in these patients. And I'm going to go through some of these key combination approaches that we're focusing on. So one of them is using a drug called pevonedistat. This was the Panther study. It was a large study of 300 plus patients, and patients were randomized here to receive either azacitidine with pevonedistat versus azacitidine alone. And the goal here was to see whether the combination could improve the endpoints of interest, which include the response rate, the overall survival, the event-free survival, etc. And we did see, unfortunately, that there was no clear improvement in the response rates. The CR rates were similar, 28-30%. There was a little bit of a signal for improved response rates in CMML, but that was a small number of patients. All in all, unfortunately, no clear improvements in response rates with this doublet over azacitidine. And disappointingly, even the event-free survival, which was the primary endpoint to try and get this drug approved, was not significantly improved. A lot of discussion and debate about this because the previous phase 1 and phase 2 studies that had been presented and published in 2018-19 actually showed a much better CR rate and a much better event-free survival. Could it be that those studies were done in centers with a lot more expertise, closer monitoring, more frequent bone marrows, other factors? And once you opened it to a large randomized multi-center phase 3 across 100 plus sites, there was some dilution of that benefit. That is one possibility. But in the end of the day, unfortunately, this drug was not approved because there was no improvement in the primary endpoint of event-free survival. And even in overall survival, unfortunately, there was minimum to no improvement. It did not meet statistical significance to show that there was a better combination effect. So we're not sure what we're going to do with the pevonedistat. It was a drug that was very attractive, and there are some efforts to see if it could be evaluated in acute myeloid leukemia and other settings, but for now it's on the back burner. Now, the other one that also has been of even higher interest and generated more enthusiasm is a drug called APR. And the APR was specifically designed for a group of MDS called TP53, which is in fact the highest risk group population of any MDS AML. The patients who have TP53 mutated disease often tend to be resistant to all standard therapies, including azacitidine, decitabine, venetoclax, intensive chemo. And so there's a huge unmet need to try and find novel therapies or combinations that could work there. And again, from the lab work and some of the early phase 1 data, it suggested that the APR, especially in combination with azacitidine, had a very good response, CR rate, and encouraging survival in the TP53 mutated patients. And so this led to a number of studies, and this was the most recent update of the pooled analysis of these data sets. And here you see that in about 100 patients who received the azacitidine plus APR, we see an encouraging response rate, especially CR rate of 43%. Historically, the CR rate in TP53 mutated MDS has been 15 to 18%. So this looks quite encouraging for a true CR rate. And we also see the number of those patients who responded eventually achieved clearance of the TP53 molecular clone, which is usually associated with a deep response, deep biological effect, and eventually often with improved survival. And we do see here that in the TP53, especially those who achieved a deep response and clearance, there was a trend towards an improved survival. Now, unfortunately, this study, similar to the pevonedistat, when evaluated in a randomized phase 3 fashion, showed a strong trend towards benefit for the CR rate, which is the primary endpoint, but did not meet the statistical p-value. And that is unfortunate because I actually believe that this drug is quite an active and effective, important drug. But if it did not meet the endpoint, then the approval is in jeopardy. So we have to wait and see the final results of the phase 3, which will hopefully be presented or published in the near future. But for now, we don't know if APR will be able to get a full approval or whether other studies would have to be done. I personally have used this drug in many patients. We were actually the lead enroller in the phase 3, Dr. Garcia Manero and myself, and we actually think it's quite a good drug. We just think that the study was overambitious and very small size, which is why in spite of seeing an improvement in CR rate, 33 versus 22%, the p-value did not meet statistical significance. And these are some of the things that affect drug development, selecting the appropriate size and expectations, which can make or break the final result. So we have to wait and see how this will play out. So now moving to more optimistic frontiers, hopefully. There are 2 ongoing phase 3s, very large studies with the 2 drugs that I think are the most exciting. We had 5 drugs that went into frontline phase 3, the pevonedistat and the APR I discussed, sabatolimab, 1 more, and then the 2 that I find most exciting, venetoclax and magrolimab. So these are the 2 we will talk about now. So venetoclax, as many of you know, is already approved in acute myeloid leukemia in the frontline setting. These studies were led by Dr. Courtney Donardo, my colleague here from MD Anderson. We have done many other combinations with venetoclax in AML, with FLT3 inhibitors, IDH inhibitors, and published on them. It's a great drug. And of course, the next logical step was to see if we can see the same benefit, which we would expect, because AML and MDS, although different diseases, are closely related in MDS. So this has led to initially, of course, a phase 1 safety and efficacy study that looked at the combination. Important here that the venetoclax duration is lower. It's actually 14 days because we do tend to see more myelosuppression in MDS than in AML. And so when we tried to give 21, 28 days, we actually had problems with very prolonged myelosuppression, severe infection. And so we settled on the 14 days as the optimal dose from the dose finding phase of the phase 1b study, and that's being taken forward. And this study enrolled about 60 or so patients. And here you see that the response rates were quite robust, with an overall CR and marrow CR rate of close to 80% and a true CR rate of 35%, duration of response encouraging at more than 12 months. So all of this looks quite good, pretty much double the response rates that we would see historically with azacitidine or decitabine alone. So this is looking very, very positive at this point. Of course, it's a phase 1b and has to be confirmed in a randomized study. The important thing to know with venetoclax is that it does cause myelosuppression, and there is a increased risk of neutropenia and febrile neutropenia. We are very familiar with this in thousands of patients now treated in AML, but this is something we also have to be aware of. And in fact, I think the signal could be even a little bit more in MDS, because in MDS, because of the overall dysplastic marrow rather than just the acute leukemia clone in AML, we see that the effects of drugs that cause myelosuppression can be more profound and take longer to revert. The good news here was that when done well, there was very low early mortality, but one does have to be aware, and we usually start our patients on prophylactic antifungal, antiviral, antibacterial when they're getting combination approaches, especially with venetoclax, but even with others, because we expect a more significant neutropenia. The survival here was quite encouraging, especially in those who achieved a response, which was 80%, so majority who achieved a response now seem to have a ongoing survival with about a 2-year follow-up. That is great. So at 2 years, majority of these patients, 60, 70% of those responders are still alive ongoing. This is definitely not what we have historically seen with HMA alone. So we think that this is indicating that this combination has a biological and clinical different benefit and impact compared to the azacitidine alone. And in fact, the randomized phase 3 study called the Verona study of aza-venetoclax versus azacitidine has now been completed very recently, 4 months ago, and we expect sometime middle of next year or a little bit earlier to see the data. I believe and hope that it will be positive and get azacitidine venetoclax approved for MDS, frontline higher risk population, as has been in the AML. We actually at MD Anderson have a number of studies already ongoing, combining both azacitidine with venetoclax, but also oral decitabine, ASTX, that I mentioned earlier, with venetoclax for a full oral regimen, which is very attractive. We've shown some of the data, and it looks very, very good, as good or better than what is shown here. So definitely trials worth considering for frontline MDS with high blast. Now, looking at the different experiences, Moffitt and MD Anderson, we see the most MDS in the country, probably in the world. And so both our groups did publish our experiences with the combination HMA venetoclax from our center versus HMA alone. And again, this is not frontline randomized study, so cannot be used for full drug approval registration. But going back over 10 years, the Moffitt group did look at their patients and found that those who received HMA venetoclax, of course, smaller group because venetoclax is only recently available last 2 years, but the response pattern seems to be very similar to what the single arm phase 1b multi-center study showed. Overall response close to 80%, CR rate 35%, double or more than double of what you get with the HMA alone. And all in all, seems to be a very promising regimen in this setting. And here also looking at survival, they see that the combination seems to be having a plateau and stabilization with an improved survival for the doublet compared to the single agent. So this is again retrospective, and we hope that this will be confirmed in the ongoing prospective recently completed randomized phase 3. And if we see similar data, then that will definitely get the combination approved and become a standard frontline therapy for MDS patients with high risk or with high blast or with both. So what are the other drugs? There's another immunotherapy approach. Immunotherapy, as many of you may know or have heard or read online, is becoming a major component of therapy in solid tumors, in lymphoma, in acute lymphoblastic leukemia, and multiple myeloma. We're working on it extensively. In fact, myself have led many of the studies with immunotherapy. Garcia Minero and our group has worked on many of these in AML, MDS. It has been much more challenging in the myeloid malignancies to develop immunotherapy compared to lymphoid malignancies. And the reason for that is the myeloid diseases often tend to be much more heterogeneous with multiple different clonal patterns of evolution and escape compared to lymphoid, where it's usually one or two homogeneous mutations that often cause resistance, and the immune system itself does not seem to be impacted as much as with the myeloid conditions, where the immune system, T cells and K cells, macrophages all seem to be impacted by the similar mutations as seen in the myeloid blast. Well, that being said, the efforts do continue. One of the immunotherapies that has shown promise is a drug called sabatolimab. There will be updated data from this combination at the ASH 2020 meeting starting in 2 weeks. And this drug works by activating the T cells to fight against the MDS AML, and also directly by targeting the TIM3, which is the target of this antibody on the surface of the MDS leukemia stem cells. So this combination has shown some encouraging response. The response rates, I have to say, are lower than what has been seen with azacitidine venetoclax, or as I will show you with azacitidine magrolimab, where the overall response rate was closer to 80%. Here we're talking about 56% or so. The true CR rate with the other two combos is closer to 35, 36%. Here it's about 20%. So as for response, I don't think this is a huge leap compared to what you get with single agent hypomethylating agent. But what's really interesting is the duration of response. So if you recall, the median duration of response we had historically seen was about 8 to 10 months. Here we're seeing the duration of responses are close to 20 months. Even with HMA venetoclax, duration of response was about 12 to 13 months. So 19, 20 months is really quite encouraging. So it could be that these immune drugs work by increasing durability, not necessarily improving response. So one could envision in the future you use something like venetoclax, achieve a remission. Once you achieve the remission, then you could either add sabatolimab or switch to sabatolimab. And these kind of conceptual ideas and studies are starting. But of course, first we need to get these drugs approved. And so there is also a randomized phase 3 of azacitidine sabatolimab versus azacitidine placebo. That stimulus study is the name of the study that is ongoing. And we hope to see data from that next year. And if that shows an improvement in the endpoint, which is overall survival, that could be another drug added. Of course, we want as many drugs possible because we know each of those will work on unique patient populations. We will find molecular cytogenetic biomarkers and eventually find ways to combine or sequence them so that we continue to have incremental improvement overall, then leading to significant survival improvements over time. So let us hope both those studies will come out next year positive with new drugs for us to use for our patients upfront. Now, the third drug that also, as I mentioned, along with venetoclax, I find to be equally exciting is a very novel approach to enhancing macrophages. So macrophages are one of the types of immune cells that work in our body. They normally help to fight against fungal and viral infections. They are the scavengers of the body. They remove dead material, debris from different parts of the body. And usually they are the first line of defense against any foreign antigen, foreign body, which includes infection, but also tumors. But tumors are very intelligent, and just as they shut down the T cell responses, they're also able to shut down macrophage response through a communication called the CD47 SERP alpha. And with this communication, tumor cells actually downregulate or put the macrophages to sleep, so to say. So what we found is that by blocking this communication using an antibody, not allowing the CD47 from the tumor cells to bind to the SERP alpha, we don't let the macrophages fall asleep. We keep them active. We unleash them, so to say, to fight against the leukemia MDS cells. And this has shown to be very effective in the preclinical model. A lot of this work was done at Stanford University. Very elegant, very compelling preclinical data published in high impact manuscripts, and also showing that combining azacitidine here was very synergistic and further improved the macrophages activities, further charged them up to fight against the MDS and the AML cells. So this has led to combination of azacitidine magrolimab, both in MDS and in AML. And here I'll focus on the MDS data. And again, here now you're seeing overall response rates getting up to that 75-80%, like with the HMA venetoclax, CR rate 33%, similar to HMA venetoclax of 35%. Duration of responses are about 11-12 months, also quite similar to HMA venetoclax. So this is looking quite good, encouraging. What's interesting with this combo, though, is that, again, similar to what we had discussed with APR, there seems to be a signal of increased response as well as increased survival in the TP53 mutated. So here you see the CR rate and the overall response rates for TP53 are 40 and 68%. And historically, TP53 has about half the CR and overall response rate of the other populations, but here we're seeing that these are being quite well maintained. And so that is a good sign, because we really do need drugs for TP53 mutation. Of course, we need drugs for all our frontline patients because survival still has to be improved, but TP53 especially so because they have a really poor survival. And so here we're now seeing over time with follow-up that the survival has not been reached with about a close to 1.5 to 2 year follow-up. That's a good sign. Number of patients are still alive, ongoing. That's great. We have some 4 or 5 years in actually, well, either going to transplant or not, who are alive. And even in TP53 mutated, we're starting to see a signal of improved survival. It's still 16 months, of course, not outstanding, but if you know the previous data, historically 8 to 11 months is what we got, even with APR 11 to 12 months. So the 16 plus months is a good beginning, and hopefully we can continue to build on that with other combinations, maybe bring in sabatolimab, venetoclax, and find a way to do triplets upfront to really improve the outcome for those high-risk groups. And then stem cell transplant is really critical. I haven't talked about it much, but for high-risk MDS, the therapies really work well to clear the disease, to achieve remission. That's the first step, most important step. But then that has to be consolidated to convert a remission to a cure. The best way to do this is to proceed with an allogeneic stem cell transplant. For patients, it's often confusing the terms remission and cure. Many doctors say remission, and I get the patients, coming back confused and saying, oh, I thought it was done. So no, remission is the first step to debulking the disease, trying to get rid of 99.999% as much as you can of the tumor. But we know that once you achieve remission, there's still going to be 1 in million, 1 in 10 million, 100 million tumor cells that will eventually come back. So it's not cure. Once you maintain the remission and eventually get to a transplant, that is often what will hopefully cure the disease long term. And here you see, among those who achieved remission and went to transplant, that's a very nice survival curve now, 2+ years, 75-80% alive. That's where we want to be, of course, even better, but that is encouraging. So remission and then curative approach with the transplant is kind of the sequence of events that we usually use in our higher risk MDS patient population. Other CD47 antibodies are also being developed. I'm not going to go into detail, but just for you to know that there are 4 or 5 different CD47 antibodies. So we hope 1 or 2 or more of them will make it. They have a little bit different properties, a little bit different predilection to cause anemia, a little bit different rates of infusion reaction. All in all, are quite well tolerated. And I think this whole group could be a nice addition, especially for the most high-risk TP53 and complex cytogenetic patients with AML MDS. So lastly, I'll just talk about a couple of other approaches. We are looking at also intensive chemo. This has not been completely wiped out from MDS treatment. There's a drug called CPX-351, which is actually a formulation of traditional intensive chemo, daunorubicin cytarabine, for our younger patients, less than 60, 65. This approach is still quite effective and could actually be quite curative. HMAs achieve remission, can improve durability, but are rarely curative. If you stop therapy, the disease comes back. But with the CPX-351, sometimes you can give finite duration, 3 to 5 cycles, and actually cure the disease once and for all. But of course, that comes at a cost of toxicity, myelosuppression, and in older patients, even very significant, severe, life-threatening infections. So we have to select the patient appropriately to consider giving more intensive chemo. Now, that being said, there is a role for it, as I mentioned, and this data was presented by the French cooperative group at the ASH meeting last year. You can see in the frontline setting, very encouraging response rates, overall 80%, CR rate 23%. If you use AML response criteria, CR rate was even better. So this looks quite compelling. And if I have a young 50-year-old patient, MDS, 10, 12, 15% blast, would I consider this? Absolutely. I would do CPX 2-3 cycles, go to stem cell transplant. That is probably the quickest, most effective, highest success rate outcome for that patient. So what about patients who have failed hypomethylating agents? This is a real population. This is a difficult population. Nothing is making a breakthrough. A lot of efforts ongoing. What we mean here is patients who have received azacitidine, decitabine-based therapy. It could be single-agent azacitidine, decitabine. It could be combination azacitidine, venetoclax, azacitidine, magrolimab, whatever it may be. And sometimes after a year, 2 years, 3 years response, they relapse. The blasts go back up, the counts drop, more transfusions. Sometimes, unfortunately, we don't even get a response. So they get 4, 6, 8 cycles, azacitidine, decitabine, and we're not seeing response. Counts are low, transfusion requirements are high, blasts are high. It's time to do something else. So here there are a few leads. The combination of venetoclax seems to work. So if we see somebody who got 6 to 8 cycles, azacitidine, decitabine, blasts have not come down, transfusion requirements not improved, platelets and white count is still low, we could consider adding venetoclax here. You do see a response. It's not as high as the frontline setting, but it's about 35, 40%. Unfortunately, these responses are, of course, not as durable. The way we would do it is do a couple of cycles, try to get the blast below 5%, move to stem cell transplant. Then we may see that this could become more durable. And then also CPX-351, same drug that I mentioned, being tested by the French frontline. We at MD Anderson are testing it, but not frontline. We're testing it for the HMA failure. So we said if somebody has received azacitidine, decitabine, azacitidine, venetoclax, azacitidine, magrolimab, 6, 7 cycles, no clinical benefit, blasts remain high, counts remain low, why not switch gears altogether and try the intensive chemo approach? This is a difficult population. The benefit is more than the risk. Can we get these people to remission and get a good number of them to stem cell transplant? We use low doses of CPX. The established dose of CPX is 100 unit per meter square in AML. But in MDS, knowing that the bone marrow is more fragile, we did a very cautious dose escalation, starting with 10, then 25, and 50, 75. And we're settling at around 50 or 75 as a dose that seems to be reasonably well tolerated and effective in the MDS population. Here you see that responses were seen in more than 70% of people. Now, again, this is in people who have failed HMA, so that's really a nice number. All of those patients, of course, could then become eligible to go to stem cell transplant once their blasts are below 5%. And you see, though, that the response duration is short. So really, this would be used as a bridging therapy to move patients to allogenic stem cell transplant as soon as possible. And we have seen that being successful in some of the patients. And then lastly, targeted therapy. In AML, this is really established. The first slide I would have shown you in an AML talk would have been this slide. We focus heavily on targeted therapy. The reason, though, is because the frequency of mutations in AML is much higher for the targetable mutation. So FLT3 is 35%, IDH1 is about 10%, IDH2 10%, NPM1 about 30%, and we have targeted therapy for all those. So in MDS, those same concepts apply, those same targets are there, and they can be targeted with established targeted therapy, but the numbers are much lower. So you see only about 5% IDH and about 10 to 15% FLT3. So only about 20, 25% of MDS patients will have a targetable mutation for currently available therapy, but that's a really important group. So we always check for that, because if we can find an IDH1, IDH2, FLT3 mutation, NPM1 mutation, even TP53, that changes our frontline treatment approach. We try to incorporate targeted therapy, which gives us better efficacy, better outcome, but often even better safety. This is our MD Anderson next generation sequencing. We do this 81 gene panel on all patients. We're probably the quickest in the US, getting results in about 5 to 7 days. Most centers are taking 10, 15, 20, some even 3 weeks to get the full panel. But our molecular group has done outstanding effort over the last 4 or 5 years, optimize this, and in 5 to 6 days, we get the full molecular data. We wait for that data, we incorporate that into our selection of frontline treatment, especially if there's a targetable mutation that actually changes our selection of what we would go with. So some of the data with targeted therapy, one of the targeted therapies approved in acute myeloid leukemia is the IDH2 inhibitor, enasidenib. It's approved in relapse setting in acute myeloid leukemia for patients with an IDH2 mutation. So we said, well, can we test this in MDS patients? This was a study led here by Dr. Courtney DiNardo and our group. And here you see that in patients who received either combination upfront, azacitidine and enasidenib, so I got a new patient, I did the next generation sequencing, 81 gene panel, 5-6 days later, I found an IDH2 mutation, I put them on azacitidine, and then look at the response rates here, 80% plus, very, very nice. But more interestingly, even in patients who have received HMA, so they got treatment somewhere, 6 or 8 cycles of azacitidine, didn't respond, sent to MD Anderson, I see them, I do the 81 gene next generation sequencing, I found an IDH2, I put them on enasidenib single agent, and here you can still see almost half of them will respond. There's no other regimen that gives us 40 to 50% response rate in post-HMA setting. So this could really be a very important salvage step for that patient to give them a real chance if we find that mutation. Now it's 5 to 10%, but for those 5 to 10% patients, it is very, very critical to look for this. And then what's really encouraging is the survival. So in the frontline setting, you see if you got this combination, outstanding survival, 1 year, 76% ongoing, you can see plateau, 2-3 years looks very, very good. So this is a great option if we can wait and check and identify that targetable mutation. And even in patients who have failed HMA, where if you remember, I showed slide 6 to 10 months was the expected survival published by us, the French, the British, and others. Here we're starting to see 22-month survival. This is really, really extraordinary. So again, we need to look for these mutations because finding them could make a huge difference for the outcome for our patient, both in frontline and relapse setting. Similarly, quizartinib is a FLT3 inhibitor. There's also another FLT3 inhibitor, gilteritinib. We again check for those mutations in our MDS patients. We have ongoing studies here at MD Anderson combining azacitidine with quizartinib or with gilteritinib for FLT3 mutated MDS and for acute myeloid leukemia. So if we find that mutation, we're seeing that adding the FLT3 inhibitor to the standard of care azacitidine seems to boost the response rate, the count recovery, the transfusion independence, and even sometimes we see the molecular clearance. So that is quite important for the future. And what about stem cell transplant? As I mentioned, the goal of therapy in most high-risk MDS remains getting patients safely into remission without too much infection toxicity, so they're in a good condition when they're in remission to be bridged to allogenic stem cell transplant. Here you see the outcomes. The 3-year survival is almost double, 48 versus 27% for transplant versus no transplant. This is a very major paper just published last year, and I think really sets the clear treatment pathway that we should give. First, the therapy, look for targetable mutations, add targeted options. If not, ideally go for a clinical trial, combining a doublet like HMA venetoclax, HMA magrolimab, 2 to 4 cycles of that, get a good remission, get the blast down, hopefully achieve even deep molecular or residual disease clearance, and then quickly move to stem cell transplant. That is where we can see the long-term curative approaches. And I think with those approaches, we'll start seeing these survival curves improve in the next 5 to 10 years quite significantly. So in conclusion, a lot is happening. I have to say that compared to 10 years, 15, 20 years ago, the amount of work, research, preclinical, translational work in MDS is 2 to 3-fold higher than it's ever been in the past, which is a great sign. That is usually what we saw in AML and multiple myeloma before a explosion of new drug approvals that improve the outcomes. And I think we're at that cusp in MDS. For low risk, remember deletion 5q, very important. Lenalidomide, highly effective, oral, safe, outpatient, easily tolerated drug. And now oral hypomethylating agents. So for most low risk MDS, you can do oral therapeutic options with good outcome. without ever needing admission if no complications, with labs once every few weeks, so can still have a reasonably good quality of life and a good long-term survival. And then for the higher risk, really finding those combinations, and these are the three still in play: the hypomethylating agent plus venetoclax plus magrolimab plus sabatolimab. And we hope that all three of these could be approved, and then we can find which patients would benefit from the most from either of those doublets or eventually the triplets. So next year will be a big year, 2023, where we will start seeing all of these data better, and then hopefully designing even combinations of three drugs to further improve that survival curve. And then post HMA, I think really the key is to find a mutation. If you can find IDH1, 2, FLT3, Sybil, there are other targeted therapies, MLL and PM1 and AML, that will come into play for MDS. That's really where we're able to get those people into a good remission, still salvage them in spite of failing HMA. Otherwise, it's tough. Intensive chemo could be used, CPX351 or other intensive chemotherapies. And then, of course, transplant more and more as we're using HMA-Ven, HMA-Magro. You see the remission rates have gone from 30-40% to 80%, which is actually increasing, doubling the number of people who are eligible for transplant. So we're seeing transplant rate go up. And I think that will be the factor that eventually leads on a population scale to a significant improvement in overall survival for our MDS patients. So that is kind of where we're at. And I'm happy to take questions, and thank you for the opportunity.
Thank you so much, Dr. Daver, for the wonderful presentation. Our first question is, do we know why hypomethylating agents fail MDS patients?
Yeah, so yes and no. We know some of it. The hypomethylating agents are very interesting, maybe one of the most complicated drugs in leukemia space. They impact many different pathways. They work by changing the epigenetic signaling. So there are many immune genes, many apoptosis, differentiation genes that are impacted. What we have seen is that in patients who progress, there are two patterns of progression: either primary refractory, meaning they receive 4 to 6 cycles of the hypomethylating agent, but the disease continues to progress and the hypomethylating agent fails, or the patients achieve a remission, and it could be a year, 2 years, 3 years, and eventually at some point the disease relapses. And we find that the main factors often at play are the underlying mutations. There are certain mutations like TP53, like deletion 17p, chromosome abnormalities that seem to be enriched in people who are primary refractory. On the other hand, in patients who relapse, we can sometimes see that there is a clonal emergence or escape of the MDS by actually developing or expanding mutations such as FLT3, RAS, that can then make them resistant and escape. So we have some understanding, and that's why we do molecular testing, because we could then pick up FLT3 or RAS and use targeted therapies, but it's still not known for a majority of the patients.
Thank you for that. Is the future of MDS treatments combination therapies and moving away from single agent therapies?
Yeah, absolutely. I think that is the future. You know, in AML, we have seen this evolution quickly in the last 5 years. We were doing single agent hypomethylating agent, either azacitidine, decitabine, for our older AML patients above 70-75 because of the high risk of toxicity, infection, and mortality with intensive chemotherapy. We already have moved to azacitidine venetoclax, which doubled the response rates, the CR rates, improved survival. But we're already moving now to the 3-drug combos, adding a targeted therapy to aza-venetoclax, adding an immunotherapy or antibody to azacitidine venetoclax. And I think MDS is on that trajectory. Of course, we need to get one of those doublets to achieve and hit the positive responses in the phase 3, which we will all know in 2023. But I think immediately after that, the next step will be to see if we can even design a safe and optimal 3-drug combination to get everybody into remission and move quickly to transplant.
Thank you. That was the next question, was in regards to transplant, is how soon do should MDS patients look at transplant? Should that be a starting conversation versus starting hypomethylating agent?
Yeah, so how soon is right away. So when we get a new MDS patient, let's say I see somebody in clinic tomorrow, I do a bone marrow. Bone marrow shows 15% blast. I will immediately call my transplant colleagues and have them see the patient in a couple of days, at least to start the process. One has to realize that transplant is a very elaborate, intricate, time-consuming process. It's not like starting azacitidine that I can do in a couple of days. Insurance clearance often takes much longer. Insurance often has a lot of questions. It's a very expensive procedure. There's a lot of pre-transplant workup. There's also, of course, finding the donor, which can take 2 to 4 weeks. So what we usually do is we will get the diagnosis. If it's high-risk MDS, we get the transplanters involved in parallel. Yes, we proceed with therapy. Ideally, at MD Anderson, it would be azacitidine venetoclax or azacitidine magrolimab, one of the frontline studies. The goal is to give 2 cycles or so, which is about 4 times 2, 8 to 10 weeks. Meanwhile, transplant in parallel is getting the donor identification, insurance clearance, transplant workup, and then move directly after 2 to 3 cycles to transplant. So we don't do it sequentially, because otherwise you do 2 cycles, you start the transplant process, it's still 6 to 8 weeks, then you end up having to continue longer and longer, and sometimes the disease could even relapse. So get transplant involved right away, get them working on everything, start the hypomethylating agent, and then move to transplant after 2 cycles would be the optimal sequence of events.
Thank you. And where does the intermediate risk MDS patients fall within that treatment dilemma of, moving quickly to transplant versus, starting hypomethylating agents? Is there any current studies about where they fall in the category of treatments?
Yeah, so there's no really intermediate in our mind. The IPSSR calls this intermediate, but if you look at all the 5 phase 3 studies that are being done, venetoclax, magrolimab, sabatolimab, and APR and pevonedostat, they included this group of higher risk, which basically included intermediate, high, very high. So intermediate risk, we basically club it into the higher risk population. Bottom line is we always will start those patients on HMA based, and more we're actually treating them with HMA combinations in the frontline setting. So from a treatment point of view, intermediate is put together with the treatment guidelines for high and very high.
Thank you. And one last question. What is your best advice for patients who are considering a clinical trial? Because clinical trials on the surface can be very scary for patients. What is your advice about clinical trials for patients?
Yeah, so my advice is to 100% think of a clinical trial. I think there's a lot of confusion, and sometimes media and online things are not portrayed carefully. So the clinical trial, remember, a big center doing a trial, we would only do it if we think it has the potential to be better than the standard of care. The whole goal of the field is always to keep moving forward. Also, one has to realize that every drug that they're getting today only got there because of the clinical trial. No drugs were spontaneously approved. And the third thing is always to ask your doctor, what is the regimen being used, right? So there are certain clinical trials that use placebo, but even then, what they're doing is giving you the standard of care plus placebo versus standard of care plus a new agent. So in any scenario, you're getting standard of care. You're not getting anything less than what you would get for standard of care, but you have a 50% chance of getting the new combination that looked exciting in the phase 1, which is why everybody's spending so much time, money, and effort to look at it in the phase 3. There are really no clinical trials where you will get less than standard of care. So the way I usually put it is, this is getting the standard of care plus, and also this is probably the best and only way to get tomorrow's medicine today, because azacitidine, for example, those who got it in the clinical trial were the ones who benefited from it. Everybody else in that time period had to wait 3 years, which some patients, unfortunately, as you know, could not wait. So absolutely looking for trials, talking to doctor about trials, talking to Aplastic Anemia, MDS Foundation, Leukemia Lymphoma Society, many avenues to learn about trials. And even physicians, I get every day 5-6 emails from other physicians, from patients, etc., asking about trials, and we actually respond. We're happy to help and guide patients. So you can always reach out to your physician, whether it's your academic physician you're working with, or even to physicians at MD Anderson, Sloan Kettering, other facilities, and many of us will actually respond and be happy to help out.
Thank you so much, Dr. Daver, for sharing your time and your expertise and talking about all this great research that is happening for patients who've been diagnosed with MDS, and very excited to hear about what's going to be happening at ASH in just a few weeks. I'm sure there'll be some new and great things going on that's going to be presented there. So thank you so much. On behalf of the Aplastic Anemia and MDS International Foundation, we'd like to thank you for participating in the program and making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support patients and their families, as we've done for the past 39 years. This concludes our program. Thank you.
Thank you.